Hello and welcome back. I'm Eric Sunset, your host of the Doc Buddy Journal. This is episode 49, and today we're joined by a guest who loves working in healthcare because there is never a shortage of complex problems to solve. Our guest today is Christie Callahan. Christie is Chief Operating Officer at Arrive Health, which is a healthcare tech company that makes it easier for patients to access affordable medications. Christie's focus there is on new product development, operations, and growth. And before Arrive Health, she was the VP of Strategy and Innovation for Member Services at CVS Health and a consultant at Bain and Company. Christie, thanks for joining us.
Thanks for having me.
It's our pleasure. Really excited to have you on the show and get you to share some of your expertise with us. Before we do, though, I bet our audience would love to get to know you a little bit better than that short intro. Can you tell us a little bit about the healthcare road you've traveled and maybe some of the problems you've enjoyed solving along the way?
Sure, absolutely. Let's take it all the way back. I'm an engineer. I studied engineering in school, and I always wanted really I liked making things simpler, right? How do you make these complex things, these complex processes simpler? How do you make them work better? I worked in a paper plant and with Bain, saw a whole bunch of different industries and ended up in healthcare. And I'm really excited that I have because I think there are two things. One, there's no shortage of really complex things that need to be made simpler. And two, the outcome is helping people be healthier. And I think, without our health, we don't have anything. And so if that can be our mission and purpose and, the outcome of making those complex problems better, then that's something worth doing every day. So
Well, it sounds like you're very much the person for the job. As you said, there's no shortage of problems to solve in healthcare, and a little simplicity, I think, would go a long way for us.
that's right. I think so too.
And our plan today is to cover a pretty wide ranging set of topics. So I think we should just jump in. And
Okay.
I think we got to start with one of the hottest topics out there, maybe second only to AI at this point in the news cycle. And that's the consumerization of healthcare and really how healthcare organizations can help foster trust in that provider patient relationship. So, what are you seeing as sort of a best practice there?
Yeah, it's a good question. And, when we step back, what we're really trying to say is how can we help patients be empowered and empowered as consumers, right? Because accessing healthcare is not just about having a doctor and, knowing your condition and knowing what needs to be done. It's also about being able to pay for it, being able to go pick it up, being able to go have, the procedure completed. And what we think about every day at Arrive Health is how can we help that purchasing decision be a purchasing decision in addition to a care decision, right? And if you think about getting a prescription, right? It is probably the only time in your life as a consumer that somebody else tells you what to buy. You don't get to pick I'll use my paper plant. You don't get to pick your toilet paper, your Charmin, right? Your doctor's telling you what to buy, and you have no idea how much it's going to cost until you show up at the counter and they ring you out. And that is the crux of, or really maybe a good illustration of why consumerism has been so hard in healthcare and why patients have felt so disconnected from their ability to get care and their ability to pay for that care and how that impacts their total health. It was interesting. We ran a survey and 64% of respondents said they would delay care if they didn't know that they could afford it. And I think that that's, not surprising. I think something that like anecdotally we all appreciate, but how can we help patients know so that they then make the best choice? And we think about that as starting with doctors because at the end of the day, our providers are key to that decision making, are key to that care journey, and consumerism in healthcare doesn't happen if providers aren't brought along as well.
Well, you're touching on an important aspect of it because on the patient side, like truly the consumer side, it's easy to tell why it matters. If they're unable to afford it, they're not going to adhere to their medication. They may skip out on the visit entirely. And this is a little bit tongue in cheek. We mentioned AI at the top of the show, but certain health systems are beginning to charge for messages into providers through a portal that then some large language model will reply to as a way to sort of throttle back the utilization of that as a resource. So it's obvious that as a on the patient side, you need to know how much your medication will cost before you get to your pharmacy. But what are some of the implications on the provider side or on the healthcare organization side for treating that patient as a consumer?
Yep, exactly. And well, I think it's both treating that patient as a consumer and being a part of the choice, right? If we say, "Hey, patient, you should have drug X," and I come back and say, "Well, I can't afford drug X," then the process is, okay, go call your health plan, see what's covered. I come back with maybe one drug and say, "This is covered. Can I take this?" Where if we can get in the hands of docs the class of drugs, the relative coverage of those drugs, so that in the office you can have a conversation and you can say, "Hey, I like to prescribe this drug for these reasons. It's $200 a month. Is that tenable for you, right? Is that something that you can afford?" And maybe my answer is no, but it also doesn't need to be $0, right? The $0 drug has some side effects that I don't want to deal with, and we can land in the middle on a drug that's both better for me, something that I can adhere to, but in a cost range where I'm going to pick it up and I'm going to pick it up every month as opposed to every other month or maybe once a quarter when I have the money. And so I think, it is how can we, in a low effort way, doctors don't need any more decisions, right? There's so much information, but in a low effort way, how can we facilitate a conversation between that doctor and that patient about whether or not you're going to take this med. I'm prescribing it. Are you going to take it? Right. I mean, that is the goal based on cost. Right. And as a part of that, we also can share, there's a prior auth that's going to be required. I just want you to know it's going to be, a few days before you're going to be able to pick up this med, that kind of stuff as well.
I would imagine when that conversation is happening about, hey, I want to prescribe you this, it's going to cost X amount. I would imagine that if that conversation happens from the point of care and not, hey, doc, I went to the pharmacy and there's no way, either through that patient portal message or you're calling into the office, wasting more time on administrative tasks for the provider. I would imagine that's way more valuable to have that data and that information right there as the diagnosis and the prescription is being written.
That's right. And I think to your point, you get two things, right? One, you've got a healthy patient, somebody that feels taken care of and feels empowered to go get their med. And two, you don't have the distraction and the cost of a call back into the office, kind of disjointed conversations in between visits, right? And not the ultimately probably not even the right outcome that you want for that patient.
Yeah. Well, I want to earmark that cost of labor in ways that automation can kind of either reduce that cost or avoid it altogether, through the lens of the ongoing staffing catastrophe that healthcare is going through. But to even
Yep.
have that information available off of a patient's formulary for a given drug, what has to happen between all of the different softwares and all of the different intermediaries and the insurance carrier and the provider and their facility? I mean, that's a lot of orchestration that has to take place to end up with, as a consumer, as a lay person, stepping outside of our health IT, boots and roots here. How come you can't just tell me how much it costs? Why is it so hard?
It's so hard. Let's start with the doctor, right? Why is it so hard for the doctor? If you think about the patients that any given doctor sees, the majority have a unique plan. They work for different companies, they have different employee benefits, they have different plans, even if they have the same health plan, right? Let's say they're all United or all Aetna, which also doesn't happen, but let's pretend, right? They've got different versions of that plan based on, what plan was right for them as well as what plans their employer selected and all of those things, whether or not they're on Medicare or Medicaid and all of the other programs as well. And so if you just start at a base level, right, that doctor's maybe seeing 50 different insurance plans for 50 different patients. And there's no way somebody knows, all right, this drug is going to be covered. This one's not going to be covered. This one has a high copay. This one doesn't. It's not just a brand generic problem. I think a lot of times we like to boil it down to say, oh, I'll just take the generic and that solves the problem. And it's not just a brand generic problem, right? It's a formulary problem. And so that's part one. How do we connect all those different insurance systems to the doc? That's the first problem that we solve. And then the second is providers use a lot of systems too, right? They're not all working out of the same system to do their work, to log your medical records, to share that information with one another. And so you also need to build some scale within the systems that the doctors are using as well. And then I think the last piece that's really fascinating is the way doctors, and not even just doctors, right? Anybody writing a prescription, the way a prescription is written and the way a claim is run by your insurance company takes some love. There's a lot of finessing that needs to happen for, an output prescription to turn into something that can actually go through the claims system and come out as a price. And, some of that happens, most of that happens at our pharmacies today. But as somebody trying to deliver those answers pre-pharmacy, there is a fair amount of translation in how we talk about drugs, how we talk about quantities. I mean, if you think about, you get a prescription and it says it's for an inhaler and it says 2 puffs a day. Well, what does 2 puffs a day mean if I'm trying to figure out what the price of this medication is going to be? So we bring all that together with a focus on consistency, right? How do we make sure that when doctors see the information, doesn't matter what plan it came from, doesn't matter how they wrote the prescription, they're seeing the price that you're going to see at the pharmacy counter, and they're understanding if there are any barriers.
Well, as you're going through that blueprint of how do you get the answer to what should be a simple question, it's obviously not simple. There's so many different layers that have to be navigated to end up with that response. I just go back to one of the first things we said, introducing you. Love to solve a complex challenge. That's pretty darn near the top of the list. And then I would imagine the cherry on top for you, Christy, would be to make that information available within a provider's electronic health record that they're maybe writing that prescription in as just a matter of course of their day.
Yeah, that's exactly right. So the way we don't believe in more apps or more portals. We really believe in, how can we meet those providers where they're at and then the tools that they're using. And so to your point, as a provider writes that prescription, gets ready to sign it, they're going to see our information and they're going to see it, as we talked about earlier, right? During the visit at a point in time when they can talk to you about it and where they can build trust with their patients and help you to have an experience that's maybe a little bit more like buying something online.
Yeah. Well, again, the benefits to the patient are obvious and apparent, but for the folks at home, you may not know that bad software is driving physicians out of the practice of medicine. They're keeping medical students from applying to med school and becoming doctors and providers and entering healthcare at all. I would love your perspective, Christy, that if you're able to provide that data inside of the software that the provider, that mid-level, that nurse, whoever is already going to be using, that, at least from our perspective, our point of view as an organization here at DocBuddy, that delights providers. That gives them something that should be so easy. We live in a smartphone world. Amazon Prime, buy it now with one click and it's at my house tomorrow. Medicine's not like that, though. It could be, but it takes a lot of
Could
people
be.
towards that end to get there. So, can you speak to that just a little bit?
Yeah, let me tell you a story from one of our doctors and then talk a little bit about the stats. So we have a pediatrician who loves to talk to us about the tool because he uses it all the time. And a lot of what he prescribes for is asthma, or other needs for inhaled corticosteroids. So think albuterol, right? Maybe somebody has croup, maybe they truly do have asthma. And it's a class where the administration type matters, right? The discus might be covered, the inhaler might be covered, a pack of inhalers might be covered, mail order might be important because it's a chronic disease state, right? All these things that the health plan is thinking about, trying to, get you the best negotiated rates, but that for providers overwhelming, right? I'm trying to help a kid, and I'm trying to help a kid get the medication they need to be healthy and live their life as a kid, right? And so he loves to tell us a story of, he wrote his normal inhaler that he prefers, and he turns his computer around. He shows the mom the drug, and he tells her all the reasons why he likes this one, but it's $200 a month. And he says, but listen, there's one that's fully covered. Here's what you got to watch out for. It's not perfect, but it's going to help your son. And she starts crying in his office because she can't afford $200 a month. It's not going to happen. And she wants nothing more than to help her child. And I think, as you think about why people choose medicine, they choose medicine to have that impact, right? To help people care for their kids, to help people care for their loved ones. And I think we got to get back to that. We got to get back to doctors that feel like they can have that kind of impact. And the reality is, cost is a part of it. Cost is a big part of it. People, like we said at the top, if I can't afford it, I'm not going to use it. And that, it is not just the tools. It is also, how do I become disenchanted as a doctor because I'm not seeing better outcomes in my patients? I'm seeing people back in because they can't afford their medication and they're not adherent. And so I think you're absolutely right. The tools have to be simple, and that can't be a breaking point for our providers, but we also have to help them get people healthy again. And I think there's a lot more to it than just good tools, maybe is the right way to say it.
That's a powerful story. I mean, that's like you say, that's what medicine is all about.
Yeah.
Well, and changing gears a little bit, obviously that's a way to delight a provider. You don't want to have patients and their parents break down in tears, even if they are tears of joy on too frequent of a basis. At least that's how I'm wired. But on the other end of this, if you're avoiding that call from CVS, the line at CVS,
Yeah.
and I have unfortunately had to endure that line more this winter than I have at some time. You're standing there 25 minutes, 30 minutes, and you're wondering what on earth is taking so long. A lot of it is bickering with the person at the register on the patient's behalf. That's too much. And what are they supposed to do? It's yes or no. You're going to buy it or not. If you don't want it and you want something else, you better call your doctor. So they do. And oftentimes you get to hear that exchange if you're waiting long enough in CVS. So if you can avoid that, call back to the doctor. Hey, doc, this is crazy. I can't pay $200 a month, and you should have known that. What does that automation, and the automation isn't the best way to put it, but that availability of information from the point of care that this is how much these drugs cost.
Yeah.
What does that do for your cost of labor, for your staffing? There's a lot to unpack here. I know I'm just kind of throwing it at you, but when you can't even make a good hire anywhere, and what if you didn't have to? I guess is what I'm
That's right. That's exactly right. So our most engaged health systems are seeing about a 30% switch rate generally on medications. So if you think about how often, you're getting calls back, your patients are experiencing some level of not the best outcome, right? Paying too much. 30% of the time they're switching medications. And the other important, and I think even more impactful to your point from a cost of doing business perspective, is 33% of the time, and at our most engaged sites, up to 40% of the time, they're avoiding prior auth altogether. Obviously, that depends on the class, right? In some classes, you're going to be stuck with a prior auth no matter what. But in a lot of drug classes, the health plans use prior authorization as a mechanism to enforce the formulary, to tell you, to steer you towards the drugs that are lower cost, the ones that they prefer, the ones that they have best rates on. So if you can avoid prior authorization 40% of the time, you are avoiding labor and delays to care that are huge. So our providers typically estimate that a PA takes 25 minutes of time to complete, but that doesn't count the, I send off this script and as soon as it hits the pharmacy, I get 2 faxes a day, 2 phone calls a day. I'm getting calls from the patient as well telling me to get this PA done, right? So that I can dispense the medication. And so if you think just about administrative burden broadly, right? And to your point, how do I want the staff in my clinic spending their time? Getting rid of those prior auths is huge and letting them, focus on patient care and everything else that's on their list.
Yeah, and just I think most of our listeners will be really familiar with prior auths, but for those who are maybe fortunate enough to not be familiar with them, I remember when electronic prior auths were introduced, and it was supposed to
Yeah.
be this great big time savings, and it did save some time off of paper-based and faxing prior auths, but still painful. Can you just give us a run through, a refresher on what all a prior auth takes?
Yeah, I can. And we're working, like, we do work in prior auth well. So let me set the journey at current state and then maybe also set a little bit of what are we doing to fix it. So I'm a patient and I encounter a prior authorization, right? That means my doctor wrote a prescription and my health plan wants to know why I need that med. They want to check it. Let's use, a great example is Ozempic, right? Our GLP-1s are trending right now. Everybody wants Ozempic for weight loss. Your plan only wants to pay if you're using it for diabetes, right? Weight loss might be good for you, but you got to pay if you're using it for weight loss. So they're putting in prior auth. What does that mean? That means that your doctor has to answer typically 5 questions. In more complex, therapies, up to 30 questions about your health. Often it's, what's your weight? What are your diagnoses? Have you taken this medication before? What's your drug history? Why do you need this medication? And that sounds simple. It is, relatively simple, but it's totally disconnected from the flow of care, right? I write a script, goes out the door. 2 hours later, I'm getting a fax or a phone call back telling me that there was a prior auth required, telling me that I need to go take action. I log into a separate portal. I put in the patient information, try to get back the right question set for that patient and that drug. I finally get the question set. I have to go into my records, look up the patient's record, make sure I get all their information right to answer those questions. And then I wait. I wait for a decision from the plan. And I check back into that portal to see what the answer is, right? Eventually I get a decision. And then, everybody goes on their way. And so what we're trying to do is 2 things. We know, like I was saying earlier, we know when that doctor is writing the prescription, right when they're writing it, if there's going to be a prior auth. And so as soon as they sign it, we start that process. We don't wait for, something else to happen. We're using the information from the EHR to get it started. We're keeping the prior auth in the EHR so they can see everything side by side. And there's no checking, right? When it gets approved, it's showing up in their workflow and everybody's able to move on. And I think, again, coming back to your point, how do we make these tools work better? Electronic is great, but if you're not in the work tool, that's not, that only solves part of the problem. It gets it out of the fax machine, but it doesn't get it into the system that I'm using to think about my work, to prioritize my day, to prioritize the day of my staff, and to make sure that, we're taking care of everybody and all the patients in the way that they need to be taken care of. Is
And it's such a
that
cool.
helpful?
Sorry, Christy, go right ahead. I interrupted you.
No, I just said, is that helpful? Do you think that answers it?
Absolutely. It painted the very painful picture I knew you would. It's ugly. It's an ugly process. And in this is just my own personal opinion, and certainly don't want to speak for Christie or our organizations, but prior auths, much like the denial of a claim for no good reason, is a way to make it harder to get the exact right care when there's a cheaper alternative that's maybe 80% as good. Speculation on my part, but there you go. But the value chain that you're discussing is really interesting, especially through the lens of provider satisfaction. Okay, we're not going to wait. Patient satisfaction, because like if you go drop off your car for an oil change at your dealership and you expect that you're going to sit there for the 15 minutes it takes to do an oil change and then drive away, but oh, actually we can't do it for another 2 hours, so we'll call you.
Right.
That breaking of an expectation that, hey, you wanted the drug now, you got a sick kid, but there's a prior auth, you're going to have to wait. You didn't know about that. Does wonders for patient satisfaction, I would expect, just to have the right expectations set. And then to be able to tack on the transparency and price as well from the point of care. And then you're avoiding that cost of the call back to the practice, call back to the facility of, what do you mean it costs this much? I need something else. So it's a really interesting value chain that you're solving for, especially keeping that data in the EHR where you can.
Well, and your point about consumer expectations, patient expectations, see, this is good. We should be using them interchangeably, is spot on, right? Which is, I don't want to go to the pharmacy if it's not going to be ready, right? If I know in the office that I'm going to have to wait for a call, or, wait till it clears and the pharmacy app that I'm using, or whatever that might look like for me, that's fantastic. And I think, the other piece that we think is important at Arrive is making sure that you're in the loop along the way. And so, when that PA gets sent off, we let you know. When it gets sent to when the questions get completed and get sent to your plan, we let you know. When it gets approved, we let you know. So that to the extent that, you want to be in the driver's seat and you want to be pushing your provider and your pharmacy to get things through, you're empowered to do so.
Yeah, that's a huge peace of mind, especially for those guardians of pediatric patients.
I know. Yeah, that's exactly right. Yep.
Well, what else is there to say about price transparency and prescriptions, either from the point of care for the provider and easing their workload, for the patient and their expectations? We're hitting all the high points here. I've really enjoyed the discussion so far.
I have too. I think price transparency as a term, as a buzzword, means a lot of different things. And, I think similar to the point you made around EPA, there was a lot of hype and maybe not so much sizzle, right? I would say something similar about price transparency, right? Like, is it real in the way that it exists today? And I think that's the point to make, right? Maybe 2 points. Price transparency in and of itself is not the solution. It's how we deliver it to docs and to patients in a way that makes it effective in building trust, in driving conversations, in driving health outcomes. And second, that not all tools are created equal. To your point, getting the right price for any given patient is a complex web. And so you've really got to know what you're doing, and estimation doesn't cut it. Prices change and are wildly different for any patient at any given time. And knowing what they paid last month is not the answer necessarily for what they're going to pay this month. And so I think that's the burden, right? The burden as we build health tech solutions is, how are we accurate? How do we get it right for every patient and every provider? And how do we do it in a way that doesn't add burden, that doesn't add complexity, but rather simplifies the conversation and helps our providers provide care and improve health?
That's really well put, and I think that's a realistic reality to work towards. Can we paint the picture of utopia that is virtually unachievable, unattainable in the current state of play? Because when I think of price transparency, I think of like your Amazon example earlier, or our Amazon example earlier. I know what it's going to cost. I know if I have to pay for shipping and tax, and I see it all in my shopping cart. You know the system better than I do, and I have spent a little bit of time in the revenue cycle world.
Yeah.
So if you really wanted to, we could figure out a hypothetical visit with certain services provided. Maybe they're going to send out for labs and they're probably going to prescribe me this. I think my diagnosis for the visit will be X, Y, and Z. Here are my CPTs. Here's my plan. And I make it sound as complicated as I can because it is complicated. You know how the
Yeah,
system works. And if you had enough time, you could find out how much that would cost you. Even knowing how the system works, I'm never going to do that
that's
ever.
right.
It's a
That's
complete waste of time. So I have a range in my head. I got to go to a specialist. It's probably going to be this much. And if this happens, then it's going to cost me more or whatever. There's no transparency in that. I mean, the real transparency would be ahead of the visit. And this is where we're getting unrealistic, panacea, maybe a very complex problem to solve for some, where you can have a price estimator before you ever step foot on the healthcare facility. That would be
right.
the lay explanation for price transparency. Thoughts?
I think that's right. I don't think it's untenable, but I do think it's incredibly complex. I think a lot of people, this is going to sound terrible, but I think, if you get some diagnosis, right, and you're going to have to go through even a couple rounds of diagnostics of some sort, some sort of imaging, some sort of procedure potentially, you're kind of just expecting to pay your deductible. And it sounds terrible, but you kind of have no other basis for saying, all right, how much might I need to pay? Right. Well, at least my deductible is kind of my ceiling, right? Like depends on the plan, but good approximation for my ceiling. And so then you're kind of working back from that and you're like, okay, well, can I pay that? Right? Let's say my deductible is $5,000. Is that something I can afford this year? And I think that's where you get it, to your point, into the conversation of, am I going to do anything? Am I going to even take the first step? And so, yes, clearly there's a need. And clearly, to your point, site of care, CPT codes, the plan itself, what you've spent so far, the provider, the specific provider, right, that is going to do the work. It is quite complex to estimate what that cost is going to be. But I think to your point, a range is a good first step. And specificity to the point that it's even better. And that's where this is why we've started with drugs. And I don't mean that as a cop out in any way. But in drugs, you have the script. You know who's writing. You know what the medication is. You know what the quantity is. You know what the pharmacy is. You know where the patient wants to pick it up, right? You know all these things. That when I'm saying, all right, you need to go get an X-ray. Okay, where are they going to take it? Who's going to do the work? And there are so many questions that are yet to be determined that it really makes that estimation step hard. And so it is not impossible, but I do think we've got to figure out how to empower the patient to make some of those decisions, get some of that information, and then, be able to provide the estimate.
I think you're spot on, especially in non-emergent care. I had to stifle a little bit of a laugh. I had an appendectomy last summer, and that was one of my more morbid thoughts. Being transported to the hospital. How much is this going to cost? I haven't met my deductible yet, so it's probably that much. And that was the number. That was it.
That was the
That
number.
easy.
Yeah, I had a baby this year. Same thing,
Yeah,
right?
yeah,
Same
right,
thing.
right. Oh, too
Yeah.
funny. Well, Christy, if our listeners want to connect with you, are you big on LinkedIn, Twitter, any social medias? Where would you point people?
Go to LinkedIn. I'm not going to claim to be incredibly active, but that's where I am most active. So if you're looking for more about me or Arrive, LinkedIn is the place to be.
Imagine Arrive Health's got a LinkedIn as well. And then looking ahead, if there's anything you either can or would want to share, what are you working on right now? What's coming down the pike? What's exciting in your world?
Yeah, I think we started, if it hasn't been clear in the last 36 minutes, right? We've been very focused on providers and getting this information to to the point of care so that it can drive a conversation. And as we think about this year, we're increasingly focused on the patient, and to your question at the top, patients as consumers. And so what I'm most excited about this year is, last year was about real-time benefits and prior auth, and really growing that provider toolkit to make sure that these tools are invaluable and are improving the provider experience and subsequently the patient experience. But now it's about, how do we bring that to patients, and how do we get them engaged, and how do we make sure that they're a part of the conversation and that they're able to have some agency over their care as well. So that's what's on the horizon for us, and excited for the year. And it's only January, so we can be nothing but optimistic, right?
Yeah, it's only January, but it's already the 16th. The way the holidays kind of stacked up, it's like I'm in a time warp. Hopefully, I feel like you've gotten more for your money than I do. Well, Christie, thanks so much for joining us. On behalf of the entire Doc Buddy team, thank you for listening. Be sure you're subscribed on Apple Podcasts, Spotify, and YouTube so that you can always get the newest episodes of the show. And until next time, I'm Eric Sunset. We'll talk to you again soon.